always a bit of unease getting back into the work week routine. I'm sure many of you are feeling it today. And, it's also fair to say this week, many people are a little bit more tense than usual as well. Our COVID-19 numbers in Saskatchewan are growing significantly with the spread of Omicron. And now school is starting back up and people are going back to their jobs after some time off. And all of this has us wondering how it will all play out in the weeks and months to come. While my next guest today can't see into the future, he can answer your questions, though, about COVID-19, vaccines, and the Omicron variant. All hour. Once again today, we're joined by Dr. Joseph Blondeau. He's head of microbiology at Saskatoon's Royal University Hospital. He also teaches about infectious diseases at the University of Saskatchewan. Now, one thing to remember, Dr. Blondeau is not part of policy decisions made by the government. If you have questions, though, about COVID-19, vaccines, or ways to protect yourself, we would love to get those calls from you. You can call in right now, 1-800-716-2221. Email bluesky@cbc.ca, and we'll try to get your questions on. You can also tweet me directly at TweeterMillsCBC. Again, that's at TweeterMillsCBC, and I'll pass your questions along to the doctor. And we're also live streaming today's show on the CBC Saskatchewan and Saskatoon Facebook pages, so you can go on Facebook, follow along, listen to the show, watch the show, and get your questions in the comments section, and we'll try to get as many of them on as well. Again, the number to call right now, 1-800-716-2221. And with that, Dr. Joseph Blondeau joins us in Saskatoon. Good afternoon, Dr. Blondeau.
Hey, Peter. Happy New Year, and Happy New Year to everyone that's listening. I hope everybody got to enjoy part of the holidays and celebrate whatever traditions are important to them at this very magical time of the year. So nice to be back on.
It's always great to have you, and a Happy New Year to you as well. And I always like to start maybe on a bit of a more personal. Were you able to get any time off over the holidays? Any well-deserved rest?
Actually, I did. I was fortunate this year that I was able to take a few days off between Christmas and New Year's. I worked up until just prior to Christmas, and had a few days off between Christmas and New Year's, and it was It was a good time to decompress a little bit, But even with that, I mean, we're still in the middle of this pandemic, and there's still lots of questions, and there's still lots of demands. So it wasn't completely free of this, but certainly it was a bit of a step back, which was nice.
Yeah, good. Well, I'm glad to hear you got a bit of a step back. Well, again, like you said, let's get right to it. I mean, a lot of the word that was probably the most popular around the holiday table, unfortunately, was Omicron, something that you'd never hear before. What do we know about Omicron, Doctor?
So we know that Omicron is the current variant of concern within the COVID-19 lineage, part of the pandemic that started 2 years ago. And we know that it's a very different bug than the Delta variant, which was the predominant variant prior to Omicron being discovered. But there are differences between, Delta and Omicron that are substantial. The first one being is that we know that Omicron is much more highly transmissible. And there are some numbers that have emerged. We've talked previously on the show about something called an R0 value. That R0 value means the likely transmission from one person to another person or to multiple people. And with the Delta variant, the R0 was estimated to be somewhere between 1 and 1.5. With Omicron, the data that's emerging is saying that the Omicron is at least at 4, maybe higher. And what that really means is that, an infected individual would be expected to infect 4 additional susceptible people, and they in turn each would be expected to infect 4 people. And so the numbers increase exponentially, and before you know what was 1 is now thousands. So that's in regards to the transmissibility. On the other side of the equation, we are starting to see some very good data emerging indicating that the risk of severe disease, including hospitalization and death, is lower with this particular variant. And there was at least some statistics released from the United States that said, the death rate with Delta could have been as high as 21%, in vulnerable populations, and that's now down around 4.5% with Omicron. We're still waiting for the data to get the breakdown in terms of which populations are the greatest at risk. Does it continue to be the unvaccinated population? Does it continue to be, say, elderly individuals with comorbid diseases? Does it continue to be individuals with comorbid diseases who are unvaccinated, which would arguably be at a higher risk? And that data is coming, but it's all not available yet because we're technically only a month into the Omicron variant sort of spreading around the world, probably 6 weeks. But you did comment, though, Peter, in your intro there about the numbers being up. Last week and the week ending December 30th, cases across Canada in that preceding week were 196,000. And so what does that tell us? It tells us this variant is spreading very, very quickly in the population, as was predicted. And with some of the changes in regards to an increase in home testing using rapid antigen tests, it's possible that we're not going to collect all of the numbers of the cases that actually exist because they're not likely to be reported. Only the ones that are captured through the public health system, our testing laboratory, Regina's testing laboratory, et cetera. Those laboratories that are hospital-based or part of the public health system that actually do the testing will still be reporting. But anybody that's doing a home antigen test, for example, those tests may not be recorded. And as a consequence, the number of infected people in the population is probably far higher than what we already think it is.
Mike, Dan, Marjorie, stand by. I just want to get one more question on with the doctor before we get to your calls, just related to Omicron, doctor. Like you said, I mean, those numbers, and we were seeing it all around the world, are startling in terms of just how significant the amount of case numbers are. And as you mentioned, it spreads more rapidly. But in terms of the less severity, is there what's the correlation? I mean, if it's spreading so rapidly, is that more concerning for people who might be the most vulnerable, or is it? What do we know about how severe this is for the most vulnerable people? Do we know yet?
Well, that data is still being collected, Peter, and sadly, there's not an easy answer to that question today because we just don't have it. I did check the Government of Canada website this morning prior to coming on to see whether or not we had a breakdown of data, in regards to unvaccinated versus vaccinated. And that data still shows that if you're unvaccinated, the likelihood of infection requiring hospitalization is still higher, but we still obviously have some cases of Delta that were part of that data set. So I think, and when we look at the typing of the strains in order to see, how deep Omicron has infiltrated the country, as opposed to displacing Delta, we're still in the collecting data phase, and a lot of that data is not yet available. So it's going to be a week or two lag. But here's something to consider, though, Peter. There was a study that was released pre-publication out of Hong Kong, where investigators there looked at the ability of Omicron to replicate in cells which are typical in your upper respiratory tract, so in your nose, your mouth, your throat area, etc. And they found that Omicron was able to replicate 70 times faster in the upper respiratory tract than previous variants. But in the same study, they showed that it replicated 20 times slower in the lungs. So what does that mean? And your lung is where we're concerned about this virus getting and causing severe infection. So what does that mean? It means you've got a virus which is behaving more like an upper respiratory tract virus and less like a virus which is going to penetrate into the lungs and cause severe disease. I realize that that's a general statement, but certainly for the vast majority of people who are exposed to this virus, they're most likely to have milder symptoms. And that as well is particularly true if you are an immunized individual. So once again, we're going to go full circle and come back and say immunization remains a very important strategy in dealing with this pandemic and also the variants that have evolved to this point in time.
All right, folks, again, our guest today is Dr. Joseph Blondeau, head of microbiology at Saskatoon's Royal University Hospital, and he'll be here all hour to take your questions. So if you have any, get those calls in right now, 1-800-716-2221. You can also submit questions on our Facebook live stream or on the CBC Saskatchewan and CBC Saskatoon pages. Again, the number to call, 1-800-716-2221. Let's go to Mike in Saskatoon. Hi, Mike.
Yeah, hi there. I was just a little disappointed when I heard that the government is going to stop giving us the total case numbers for the day and the amount of people being tested. Because that's one of the things that I used as a barometer to find out what's going on out there. I would take the amount of positive cases divided by the amount of people that got tested. And I know, with the Delta variant, it was as low as 2% when we, straightened out a little bit and with social distance. But lately, like the last test from the last day, I guess, before New Year's, it was, 2,000 tests divided by 700 positive, which tells me that's 27%. So I think that the government's just trying to, I get it. I don't believe either side. I mean, they're pulling us in two different directions, but the one thing I do want to know is a positivity rate at all times, and that's the one piece of information that no one talks about. But anyways, I just like what your thoughts are on that. Thanks.
Yeah, I can actually speak to this. One of the trends that we have noticed here at University Hospital, so we're one of the two main testing sites in the province here and at the provincial laboratory in Regina. So we're doing, on any given day, we're 50-50, sometimes 60-40 split in testing. But one of the things that we have noticed over the last a month or so, and certainly a little bit longer, is that the number of specimens coming in for testing has gone down. Our positivity rate has, in fact, gone up. So what does that tell us? It tells us that fewer people are showing up to get tested for whatever reason. And for that particular reason, it's now hard to guesstimate whether or not the number of positives we're seeing out of a lower number of specimens being submitted is a true positivity rate, or is it very, very skewed to those patients who decide to go and get tested and doesn't account for anybody at home that has either taken a home antigen test or didn't take a test at all, but is still nonetheless positive. So it's not my responsibility to either defend or to criticize governments, but the reality is that I think in this particular instance, the government is correct that the numbers that they would provide in regards to daily numbers and positivity rates would be a false representation of what's actually going on in the province, because we're not capturing all of the testing, and people are not a lot of people are not showing up to get tested.
All right, Mike, thanks so much for calling in. And Dan, just hold on quick before we move on to you. I know, Dr. Blondeau, we're going to be talking about rapid tests today, and just based on what Mike said, I was just curious, too, based on, the Premier and the province's announcement last week that they're moving away from daily case numbers as a main indicator and things like that. Does a reliance on rapid tests and less information in the public and in the media affect, studies and healthcare, the way the healthcare system responds at all?
Well, it does change the types of data that gets generated, that's for sure, and then how that data gets used. I mean, I could tell one story with a set of data, and somebody else can turn around and tell a different story with the same set of data. And so I think we need to be mindful of that as well. But if everybody in the province decided that they wanted to show up for testing, we wouldn't have the capacity to test tens of thousands of people a day. And we're seeing that actually be problematic in Ontario and Quebec, where testing demand may be exceeding testing capacity. And so then moving to home-based testing with rapid antigen tests is, in fact, a reasonable strategy. There's absolutely nothing wrong with it, provided that the individuals that are taking the tests at home abide by the results. So if you're thinking that you're going to be negative and you test yourself and you're positive, then you have to treat yourself as being positive and then govern yourself accordingly. And I think the rapid tests are doing the job that they're expected to do when they're being used by individuals at home or in the workplace. And I think it's just another tool that we have in order to identify people who are positive for this virus. So I don't have any concerns with that at all.
All right, let's go back to the phone lines. Dan is in Saskatoon. Thanks for standing by, Dan.
Hi, Dr. Blondeau, and Happy New Year, and thanks for your continuing assistance to Saskatchewan. On the
pleasure.
rapid antigen tests, I was listening to Dr. Peter Uni on the National last night, and he was talking about the rapid tests and saying that a negative result on the rapid test does not mean that you're not able to transmit Omicron, and perhaps that is as a result of what you said earlier, that 70 times or the respiratory in the nose is 70 times greater with the virus than previously. So even if you test negative with the antigen test for COVID, you still may be, according to Dr. Uni, you may still be able to transmit the virus. So a positive test, in his view, meant that you have the virus and should self-isolate, but a negative test really, and based on what he said, my understanding was pretty well useless.
Yeah, so first of all, we have to recognize that every test has a limitation, both in terms of detecting positives and detecting negatives. But we do evaluations in order to determine things like the sensitivity and specificity and positive and negative predictive values. These are all equations that we can apply to almost any test in order to determine how well the test performs when it's compared to, say, a gold standard type of test. And we do know that the specificity with the home antigen test is very, very high, meaning that if you're negative, it'll call you negative. And we know that it lacks a little bit in sensitivity when it's compared to a PCR test, but it's nonetheless a respectable value. And there are a couple of other factors that go into testing. One is the quality of the specimen that was collected. Now, to exaggerate, if you wave the specimen around in the air and then you test it, you're most likely to be negative. But if you stick it up your nose and you get a good specimen, then that's probably a very realistic indicator of what's going on with you. The other thing that you have to take into account is whether or not a person is symptomatic or not. And if you're symptomatic, then the probability, and if you're symptomatic with Omicron, for example, or another variant, then the likelihood that the test will pick that up is very reasonable. But we do have to remember, and this is where, unfortunately, the world gets complicated that I live in, is that we have other respiratory viruses that are out in the community and circulating that will give you similar symptoms to what Omicron or other COVID variants can give you. And as a consequence, you could be symptomatic but negative for COVID, but still have a virus, but it's not COVID. And so all of these factors then go into how a test should be used and how it should be interpreted. And if in doubt, one could always go to a test center and have a test done through the hospital system if a person was really concerned about whether or not their home antigen test was accurate or not. That is always available as an option.
Okay, it was my understanding again that if a negative test, even if you have no symptoms, because it doesn't mean anything, because even if you're asymptomatic, you can still transmit the virus.
Oh yeah, no, false negatives are possible. That is definitely true. But once again, it's about probabilities. So let's just say that I have not interacted with anybody outside of my household in the last month. Just me and my wife. And I'm not symptomatic, and I took that test and I'm negative, that the likelihood I'm negative is very, very high because I wouldn't have been anywhere where I would have captured that virus. Correct. If, on the other hand, you're interacting with other people, it is theoretically possible that you could be infected, home antigen test negative, and still be infected with the virus. That is definitely a possibility. And so for that reason, we always tell people that in addition to testing, there are other measures that continue to be important. Distancing and the use of masks and limiting your social interactions and even your work interactions are all still important components of dealing with this pandemic, not just the testing alone. You raise a great point, but every test, even the tests that we use at the hospital, have limitations. There is a finite limitation to every test that we use.
Okay, so if I go to a meeting and I take the test before I go to the meeting, and I'm negative, and I've been working around other people,
You should still
can I
be
have
masking
confidence
and.
that
Yeah, I mean, you can have as much confidence in the test of the result as we have. Yes.
Great, Dan. Appreciate you calling in. We got a couple callers waiting on the line. I want to get to. We'll come back to if these callers don't ask about rapid tests, I'll come back to it. I have a couple more questions that I'm sure others want to know as well. But Marjorie has been very patient. Let's go to Marjorie in Regina. You there, Marjorie?
Hi there. Hello, Dr. Blondeau. I have a question that isn't specifically about Omicron, but I've been wondering about this for a while. I've ordered some N95 masks, which aren't here yet. I would like to ask about the blue surgical masks that everybody's wearing and how effective they are at blocking transmission, both outgoing and incoming, because I was told that they only block the larger droplets, and not the very tiny ones which are free-floating in the air. And I'm just wondering if you could comment on that.
Yeah. So we, as you know, prior to the holidays, there was a recommendation that came out from the government that talked about N95 masks, if you can get your hands on them. And N95 really means that these masks have been tested and have 95% efficiency in blocking particles that could be harmful to you, including viral particles. In regards to surgical masks, there's numbers floating around that indicate that the efficacy is somewhere in the range of 30%. It could be a little bit higher than that. I've actually been trying to get, more concrete numbers. And you may have heard me on another radio station or on a TV interview recommending that if you can't get your hand on an N95, then the next best thing might be to double up your surgical mask. And the reason for that, and here it's an analogy that somebody else used, and I'm taking it from them. It's not an analogy that I developed. You're familiar with Swiss cheese, right? And you know that Swiss cheese has holes in it. So if you took a number of slices of Swiss cheese and you line them all up, the first piece would have holes, but the second piece would cover some of the holes in that Swiss cheese. The third piece would cover more holes. And so the more layers that you have, then the less likely that you'd see any holes in the end. And so by considering doubling up your surgical masks, you're in essence doing a similar type of thing. You are reducing the likelihood that particles can get through. But masks are a funny thing. And I would just, Peter, for a moment, just like to expand on this. I see people all over the place wearing masks incorrectly. They're wearing them below their chin. They only put them up when they think somebody is watching them. A lot of people wear them below their nose. And many people actually wear them where there's big gaping holes on either side of your face, because they will do a crossover 8 figuration on their ears, which gives that gap. So having a mask on is one thing, wearing it correctly is the other thing. Because the minute you allow this variant an opportunity to reach your airway, it's going to take it because it's so highly transmissible. So you can have the best mask in the world, but if you're not wearing it correctly, then its effectiveness is reduced. So I think there's two things there, one of which is obviously N95s if you can get them. If not, then consider doubling up your surgical masks. And there are now some experts that are saying cloth masks are useless. And if you're using a cloth mask, you really should consider stepping up to a mask that at least has some data to show that it has some level of effectiveness.
Well, thank you for the suggestion about doubling the masks. I guess I'll try that. But I just want to see if I understood correctly. You said 30% effectiveness maybe for the blue surgical masks. Now, does that apply more to the breathing out and affecting other people? Like, what is the effectiveness for the person
both ways,
wearing
as I understand it. Yeah, both ways as I understand it. And I don't want you to be fixated on 30%. It was one of the numbers that I found. I'm looking for more so that I could give a more definitive answer. But just so that the listeners know, Peter, I currently am double masking with surgical masks wherever I go. I do have N95s. I have been fitted for N95s. I wear those in certain circumstances, but when I'm not wearing an N95, today I am double masking with surgical masks.
So then the, say, double masking with the blue surgical, is that effective against the tinier particles that are airborne? Or is that just for like coughing and the larger drops?
You know, sadly, I can't answer that question with any definitive answer because we don't have that data. But I would say to you that it's certainly better than either a single mask or not masking at all. And that in and by itself is certainly worthy of consideration. Sadly, as we said in the introduction, we're only, 4 to 6 weeks into Omicron, and, data is becoming available every day, but we really don't have Omicron-specific data in regards to absolute effectiveness, and that's going to be a little bit more time before we have it.
Great. Marjorie, thanks so much for calling. We got to move things along. And folks, if you're just joining us, our guest is Dr. Joseph Blondeau, head of microbiology at Saskatoon's Royal University Hospital. And we want to get all your questions in on Omicron, any health tips to protect yourself, rapid tests, anything like that. You can give us a call, 1-800-716-2221. Again, 1-800-716-2221. Jacob, Wendy, stand by. I'll come to you in just a second. I want to get some of our Facebook comments on because we haven't had any questions from there yet. Dr. Blondeau, Leanne on Facebook wants to know what you know about children hospitalizations in the United States regarding Omicron. Do you know anything about that?
Not as much as we do about some of the previous variants. We do know that some of the previous data that was just released by the CDC on hospitalization actually indicates that hospitalization with children remained low, but the concern going forward is a mathematical concern. And by that I mean, if you had a virus that had a low transmissibility, and let's just say 2% of people were going to be hospitalized as a result, but it only infected 1,000 people, then you would only have a small number, 20 people, that would end up being hospitalized. But let's just say that you have that same 2% hospitalization, but now the percentage of the population that could be infected is far greater than that 1,000 people. Let's just say it's 100,000 people. Well, now 2% of 100,000 is a lot different than 2% of 1,000. So the concern going forward with the U.S. is, and in Canada and other countries that are collecting this data, is what are those hospitalization rates going to look like, particularly in vulnerable populations? And the vulnerable populations obviously would be those that are unvaccinated and certainly those that have underlying medical conditions. And we simply just don't have that data. We have it from the previous variants, which says that hospitalization rates in children were generally lower, and serious disease and deaths were generally lower, but long COVID was definitely a possibility in children as well. So I think there's legitimate concerns there, but we probably need another 2 to 4 weeks of data before we'll have an answer to that question.
All right, one more from Facebook before we move on, and it's about vaccines, which we haven't talked much about today. Candace asks on Facebook, with the Omicron variant being described as common cold symptoms, why would a booster be recommended to those who already have 2 doses of the vaccine?
Because we do know that antibody wanes over time, which is a natural phenomenon with this virus. Your antibody level drops. And, we don't fully understand, Peter, and I think we need to be clear to people that are listening. We don't fully understand whether this virus would be a lot worse for us if a greater percentage of the population was unvaccinated. We simply don't know that. So I think we have to attribute at least part of the mildness of the disease that's occurring in a large percentage of the population as being related to the fact that they're vaccinated. If you believe that, then having a booster in order to raise your antibody level back up to give you that level of protection you need in order to stay out of the hospital makes every bit of sense to me. So that's the reason.
Great. Thank you so much, Doctor. Okay, Jacob has been waiting some time. Let's go to Saskatoon. Jacob, what are your thoughts?
Hi, yeah. My question was just along the lines of what that last Facebook question was. It seems that the vaccines and the even with boosters, it's pretty ineffective at preventing you from getting Omicron. There's studies out there, and I know people in Alberta that have been double vaxxed and boosted and have gotten it. If it's going to, as transmissible as it is it time for maybe some more government measures like moving to hybrid learning or going the Quebec route and having a lockdown again?
Again, as Peter pointed out, I'm not involved in those discussions, and I can only speculate, as can anybody else. I think that we're going to see this virus move through the population. I am aware of family or friends of mine where dad has been vaccinated and boosted and is now tested positive for Omicron. Mom remains negative even though she's in the same household, and the adult children are also positive now. But in the text I received this morning, they're all doing well. They were mildly symptomatic. And so I think we would have to argue that the vaccine has done something. I think it's a good time, Peter, now to also bring up that there are discussions that are going on, at organizations like the World Health Organization saying that, COVID-19 is not going away anytime soon. So now we have to prepare to move forward to live with this virus and potential variants. And what will that look like? So does that look like it's going to be, an annual or maybe 2 or 3 times a year vaccine booster program? What will happen if there's a new variant? That's anybody's guess. But it's clear that what Omicron is showing us is that at least for the vast majority of people, and whatever that's due to, it's behaving more like a respiratory virus and less like a virus that of the previous versions had such high mortality rates. So are we transitioning to something here? I don't think anybody's prepared to say that at this point in time, but it's certainly a discussion point now.
So then the reason you're recommending vaccination boosts is just to reduce the potential severity of it?
The severity requiring hospitalization and the need for intensive care, absolutely.
Okay. All right, well, thank you.
And thank you, Jacob, for calling and standing by. Let's go to Wendy in Saskatoon. Hi, Wendy.
Yes, hi. I understand that Omicron is airborne, and what I'm wondering is, I've not heard anyone say anything about this. How long will the virus stay viable in an enclosed space? For instance, I live in an apartment buildings. We use the elevator all the time. If somebody had it and was in the elevator, how long before that virus is no longer viable?
I wish I could answer that question. I simply don't know. We don't have that data. Now, what we do know is we do know that early in the pandemic, there was a lot of work about how long the virus could survive on various surfaces, metals, woods, paper, those types of things. And there was some data saying that, virus was detected up to 48, 72 hours after, it was deposited on that surface. And I think if you recall back to those early days, we recommended that high-touch surfaces receive regular decontamination in order to reduce the likelihood that any virus is lingering there. I would still suggest that that's a reasonable thing to do. But in regards to your specific question about how long does the virus hang in the air, with the Omicron variant in particular, I simply don't know. I've not seen any published data or even any pre-published data that would give us an answer to that question. I'm sorry.
Okay, that's what I kind of was expecting to hear from you, because I have heard nothing either, and I've been listening for that. Thank you very much for your help today and for everything.
You're most welcome. Thank you.
Okay. Yes, bye-bye.
Wendy, thanks so much for calling in. Just quickly, Dr. Blondeau, I want to get another Facebook question on because it's somewhat related to that. Julie was asking just how infectious is Omicron and Delta on surfaces. What do we know about COVID-19 and surfaces?
Well, again, the data we had goes back to the earlier part of the pandemic where, we had some research into surfaces and how long the virus survived. And there are a whole bunch of variables that have to be taken into consideration. and certainly humidity is one of them, because we know this is an envelope virus, and we know that the envelope tends to be unstable under certain conditions. And so there was data saying, 24, 48, 72 hours, depending on the surface. I haven't seen anything specific for Omicron that substantiates those earlier findings. So I can't answer it because there's no data specifically for Omicron that I have seen. If it's out there, I still have to find it. So I don't know. But I don't know that there'd be any reason to suspect at this point in time it would be lesser than any of the previous COVID variants, but I could be wrong on that point.
All right, let's go back to the phone lines. Yvette is in Regina. Hi, Yvette.
How are you?
I'm doing well. What's your thoughts?
I was wondering about what the doctor's advice was in terms of if a person has symptoms, might just be a cold, and if they isolate, should they still be tested or test themselves, or is it good enough if you just wait till all symptoms are gone until 48 hours after?
Well, yeah, I mean, you certainly could isolate, but if you're symptomatic and certainly if you're a contact of a person who's a known positive, then you are required to self-isolate for 14 days. That has not changed, particularly if you're symptomatic. I think the easiest way to get the answer to your question is to get tested. If you're symptomatic and you want to know whether it's Omicron or not, or if you want to know if it's COVID or not, get tested, and then you'll have your answer. And if you're negative, then you're symptomatic for some other reason, and it's not COVID related.
Okay, and related to that is how long after you have cold symptoms is it safe to go for a booster shot?
Oh, I had the answer to this question. I think it's right after, like within 48 hours after being symptom-free, is what the recommendation was.
Sounds good. Thank you so much. Thanks for all your work.
You're welcome. Thank you.
And thank you, Yvette, for calling in. All right, folks, the phone lines are wide open now. If you want to get a question on for Dr. Joseph Blondeau, head of microbiology at Saskatoon's Royal University Hospital. Give us a call right now, 1-800-716-2221. Email bluesky@cbc.ca. Again, that number to call, 1-800-716-2221. We only have about 10 minutes left, so get those calls in now. But, Doctor, something that you had mentioned that I wanted to ask just about, again, obviously I do far too much reading of comments and things, but it does help me bring questions to you. And I think, both optimists and COVID skeptics alike say this is Omicron and the less severity that we're seeing in a lot of cases is a sign that future variants will be milder and that we can live with them. What would you say to that?
Well, we know from the data out of South Africa that the Omicron variant appears to have picked up a bit of genetic material from another coronavirus, a virus that's associated with seasonal cold symptoms. So if you recall, a virus called rhinovirus is the number one cause of the common cold, and coronavirus is the number 2 cause of the common cold. And so by picking up a little bit of genetic material from the common cold virus, it might have given it some of its characteristics. It probably did give it its characteristics that it has right now, and starting to behave more like a cold virus. If Omicron was to further mutate, the concern would be not that it behaves more like a common cold virus, was that if it happened to mutate and now became more pathogenic and highly transmissible, then that would be a concern of staggering proportions. So one never knows when these organisms continue to evolve what the next mutation might bring. That could be either a challenge or a blessing. And so fingers crossed that Omicron doesn't change to become more than it already is, and that if it is going to change, that it becomes lesser than what it is. And that would be the best case scenario.
Great, thank you. And Doctor, one other thing that I wanted to come back to, we were talking a lot about rapid tests, and I think this is news a lot of people can use, is just, can you walk us a little bit through what's the best way to actually use them if you're administering yourself at home? We've been hearing a lot about, whether you should be doing your nose, your throat, both. What would you suggest?
Yeah, I mean, I think that I don't want to say anything which differs from what the manufacturer's instructions are with the test, but I think the best swab, continues to be a nasopharyngeal swab, so, sticking it up your nose. And the reason being is because, at least with previous versions of coronaviruses, the nasal passage is a little less warm than the rest of your body, and that's a bit more ideal for coronavirus replication. So to me, I would think that sticking the swab up your nose is the best specimen to get. But you have to make sure you get a sample. So you just can't put it up there and not touch anything. You have to get it up there, and you have to touch some surface of your nose in order to make sure you're picking up enough material where the virus can be detected. And then follow the instructions on the kit as to how to perform it correctly. Make sure that you have the right amount of diluent and that the specimen is properly prepared, depending on the test. And that you wait the proper incubation time, if you will. If it's a 10-minute test or a 15-minute test, that you don't try and read it too quickly. And they're relatively straightforward. They're easy to perform, but they have to be performed correctly.
All right, let's get back to the phone lines. John is in Saskatoon. Go ahead, John.
Yes, I would like to know what nutrition protocol one can follow to required to get help when it comes to the COVID-19 virus. Surely there's a nutrition protocol to help one out to avoid the virus or to help in controlling it.
I'm sorry, was that nutrition?
Yes.
Yeah, I'm not aware of any dietary protocols that are in place. The only thing that I'm aware of is, trying to be in a good state of health and to do the things that we believe are important. And I know there are still those people out there that don't like to hear me say this, but immunization or vaccination is still the cornerstone of our pandemic response. And that, along with some of these other public health measures, continue to be important. I'm not aware of a dietary algorithm that offers protection if you go down one arm more so than the other. I apologize. Maybe as somebody who's a dietitian, may be in a better place to answer that.
Great. Thanks, Dr. Blondeau. And John, thanks for calling in. Let's go to Doris and Mervyn. Hi, Doris.
Hello. I just tuned into the program not too long ago to hear the tail end of Dr. Blondeau's statement about, I think he said if you test negative on a rapid test at home, that you can feel as confident with that result as if you go to the hospital and get a PCR test. Did I hear that right, or am I wrong?
No, we do know that PCR tests are more sensitive and more specific than the rapid antigen tests. I need to be absolutely clear about that. What I'm saying, though, is that if you're at home and you're asymptomatic and you're not at risk, and you have a negative test, I think you can be comfortable with that test is an accurate test. We do know that we have people who are at home who have symptoms and take the test and it's negative. And maybe infect it with something else, or may in fact have COVID. And if that's a concern, like I'll give you a scenario. Let's just say you were exposed to somebody who's a known positive. You develop symptoms, but you test negative. In a situation like that, I would probably recommend, if I was asked, that you follow it up with a PCR test, just because every test has a false negative and a false positive rate, so it has a lower level of detection. But if the test is used in accordance with how it's meant to be, and in those instances, most of these tests are used when you're asymptomatic in order to determine whether or not you're positive and didn't know it, as opposed to telling you that you're negative when you don't feel any symptoms. But in the situation where I described, then I would be confident in the result, yes.
Doris, thanks so much for calling in. We're going to try to get as many people on here before we run out of time. And Doctor, I promised Deanne that I would ask about if we have any vaccine updates for kids under 5.
I have not seen any data, Peter. I look for it every morning. It's not been released yet, or at least it's not been released in a place where I can access it. So I don't have it.
Okay, thank you so much. All right, let's go to Al in Saskatoon. Hi, Al.
Yeah, have any of the lessons learned in fighting the AIDS virus been used in fighting the coronavirus? And why is it that there's a vaccine against the coronavirus and no vaccine against AIDS?
AIDS is a much more complex infection than is COVID-19, and and there's been a lot of vaccine work related to HIV, and I think that's probably outside the realm of this particular discussion. I think that where the emphasis in regards to COVID-19 came in regards to the rapidity with which we saw a vaccine developed and released to the marketplace really had to do with the fact that this was a global pandemic with essentially the entire population being at risk of the world. And so I think that's why the emphasis was adjusted in this particular way. But I wouldn't take that to mean that there's no work going on with HIV and vaccines. And in fact, there are some messenger RNA vaccines for HIV that are under investigation.
All right, Al, thanks so much for calling. We're just about out of time, Dr. Blondeau. I want to ask you one last question from Lindsay, who is following along on this Facebook Live. Lindsay says, I have friends who worry that vaccines compromise their own natural immunity. What does science say about this?
It does not. We're exposed to stuff every day, Peter, to which the body has to defend itself. What you're doing with a vaccine is that you're giving the body something which you hopefully will recognize as being foreign, to which it will then raise antibody and protect you. It does not suppress or it does not compromise your immune system in any way. If anything, it makes it better.
Any thoughts for people who say, I trust my own natural immunity?
Well, you know what? You certainly can do that, and the body is designed to fight off infection. The problem is that some people will get such a bad infection, the body is unable to fight the infection in a way that allows the patient to survive. So if you have this massive inflammatory response, then patients end up dying as a result of the body's massive response to infection and not necessarily to the infection itself, if that makes sense to you. And so by having a vaccine, you're helping the body to recognize a pathogen earlier and to block it before you get to a point where you're severely ill. And that is the foundation of immunization and something that I think we all really need to seriously consider.
Well, Doctor, it's always informative, always great to have you. Glad to hear you got a little bit of a break, and thank you so much, and I look forward to talking to you again.
It's my pleasure. Everybody be safe out there, and once again, Happy New Year.
Dr. Joseph Blondeau is head of microbiology at Saskatoon's Royal University Hospital. He also teaches about infectious diseases at the University of Saskatchewan, and we're also very lucky to have him on the show. I believe it's every 2 weeks, right, Joelle? Yeah, every 2 weeks? That sounds about right? Yeah. So, again, thanks for everybody for tuning in, and to Dr. Blondeau. If you have any more questions or comments, you can always email bluesky@cbc.ca or give us a call on Talkback, 1-800-661-7540. Again, 1-800-661-7540. That's all our time together today. Join us again tomorrow between noon and 1 here on Blue Sky. Until later today, I'll talk to you on the afternoon edition. Stay healthy, be good to each other, folks, and remember, you'll never walk alone.